the fourth session is going kind of away from COVID, coming back to another piece of work that APO has been working on, and this is about use of routine data for policy decision making in decentralized countries, comparing the experience from Philippines and Indonesia, and I'll say kind of away from COVID because COVID was part of the conversation as this was designed and it was being done. So I think we may see that challenges of COVID came into this particular research as well. We have 4 people in this session. We have Karen Grepping. Karen is Associate Professor of Public Health at Hong Kong University, prior to which she was working in Wilfrid Laurier University and New York University. She is got a PhD from Harvard, and her focus for us, her focus is primarily about using of the large routine data and how they can be used for decision making. In addition to Karen, we have Dr. Raymond Sarmiento, who is the Director and Research Assistant Professor at National Telehealth Center at UP Manila. With Raymond, we also have 2 other colleagues. We have Dr. Tiara Martias from Gajah Mada University, Indonesia, as well as Dr. Lutfan Lazuradi, who is the Secretary of the Department of Health Policy and Management at the Faculty of Medicine in Gajah Mada University, both from Indonesia. And they're both going to, the 3 of them are going to be talking about the Philippines and Indonesia situations, while Karen is going to start with focusing on sitting in the background and putting up the concepts in place. So with that, I would like to greet Karen. Thank you for joining us, and thank you for joining us, all the 3 other panelists, and hand it over to you.
Hi, can everyone hear me okay? Great. So thank you, Nima, and thank you to everyone for organizing this interesting conference and for the invitation to speak with you today. As Nima has sort of introduced the title, I won't try to read off this long title, but sorry, I just want to make sure I'm full screen here. Apologies, I'm having technical issues. So our focus for this project is really on health information systems. So just by way of background, I think everyone here is aware that health information systems are critical to health systems. In the WHO framework, they are considered one of the primary building blocks of a health system. At the same time, too, there's a lot of talk about, as important as they are, they tend to get neglected. They tend to get get less glamorous components of the health system, and therefore aren't given as much attention. However, at the same time, too, all other aspects of the health system rely upon the data that come from these health information systems. And our starting point for this project is really that policymakers need these data in order to make the right decisions, whatever it is you are interested in. And that can be decisions around universal health coverage, that can be decisions around primary health care, that can be decisions around COVID-19. In order to have this information, of course, they need not just quantity of data, but they need quality data. And so by that, we mean that the data are reliable, they're timely, they're available also at the right level for the types of decisions that need to be made. And this is seen as really critical to the policy decision-making process. Over the last decade or so, there's been rapid adoption and uptake of digital platforms across the Asia Pacific region. And so we see it as something that's been quite important and hopeful sign in terms of strengthening of health information systems in various international contexts. Yet at the same time, we've seen less commensurate uptake of the use of these data. So it's not just that the data exist and that are generated, but they actually get used for the types of decisions that we think are important. And the data that we've decided to focus on for this project are specifically those that are sourced from routine health information systems. And by that, we mean the data that are collected at regular intervals from health facilities. That does actually vary in different international contexts in terms of what that means, but it's specifically that aspect of the health information system, which is actually a bit broader, that we'll be focusing on in this project. Previous research has suggested that there is an overwhelming preference amongst decision makers for data coming from alternative sources, for example, household surveys, which can be more easily disaggregated along socioeconomic lines, and also can be compared to populations. And so in that sense, there's a feeling that those data are preferable. But at the same time, too, they're not as available as regularly. Therefore, there's a need to find interim data sources and data that provide information on a broader spectrum of questions that aren't necessarily available from household surveys. Data quality has always been seen as one important barrier to the further uptake of these data. So as Nima said, this project didn't start out to be looking at COVID-19. However, of course, COVID-19 has happened and therefore was an important add-on to this research project. And in fact, we see it very much as a way of thinking about how it's changed the demand and perhaps how it's changed the way in which decision makers have been forced to think about using data from health information systems. So our overarching research project objective has really been to study this behavior in terms of how do policymakers use data from routine health information systems to identify and to identify factors that prevent the greater use of these data. Specifically, we've focused in on universal health coverage. We think the types of decisions that we're interested in could be very much aligned with UHC as opposed to narrow types of questions that others have used to investigate use of data in health systems previously. So I won't read all these research questions, but these are our specific research questions in terms of how the data are getting used, what are strategies to help overcome barriers, and of course now how has COVID has changed the way in which data are being used. So we've decided to do this project across two countries, Indonesia and the Philippines, both of course because we have wonderful partners in both places, but also because they present as interesting case studies in that they're both highly decentralized health systems and both making very important steps towards achieving universal health coverage. And this project is based off of two existing frameworks, one known as the PRISM framework, which is a framework that's been developed to understand data performance of health information systems, specifically framing data use as the output of a health information system and understanding the determinants of that process. And then a second framework, which is known as the DDU, or Data Demand Use Framework, which also is a complementary type of framework, but understands why data are not used due to specific constraints that might be on that process. So our research design, which although will vary in the two different countries, but is relatively common, involves a number of components. First, a scoping review, as well as a landscape analysis, and then interviews with decision makers in the two countries. So in terms of where we have finalized all our data collection. We are mostly done all our transcription and coding, and we're just at the point of where we're getting to our data analysis. However, luckily, we do have enough findings so far that each country team will be able to share with you where they are with regards to their own country level findings. So the two speakers, they're both on the call. First, we have Dr. Francis Sarmiento from the Philippines, who will be speaking on behalf of that research team. And then two speakers from Indonesia, Dr. Lazurati and Dr. Marthias. So I will stop there and I will hand it over to the other teams.
Thank you, Karen. Thank you, everyone. Let me just share my screen now. This part of our presentation will be more about how we are doing it in the Philippines as it relates to routine health information systems. As mentioned, the title of our study is Identifying Strategies to Enable Greater Use of Routine Health Information Systems. by policymakers to achieve universal health coverage in the Asia Pacific region, comparing to case studies in Indonesia and the Philippines. So just a general disclaimer that the findings presented in this forum are preliminary, and our final analysis and results will be submitted for publication in a peer-reviewed journal. We are also working towards being able to present this in other conferences and fora, and so we hope that we'd be able to get to share all of our results with our local stakeholders as well as those from the WHO and the APO. Just a quick outline of our presentation. I will start off with the theoretical framework that we are following in order to identify all of the factors affecting RHIS data, quick stats and demographics for our leg of the study, if you will, the flow and the use in the Philippines, and in the barriers to greater and better use of routine health information systems data, and strategies on how to improve them, how COVID has affected RHIS. I'll dig in a little bit deeper on that, and universal health coverage and RHIS and how that has changed in the last 19 months. Our theoretical framework is anchored on the performance of routine information system management, or the PRISM framework, which focuses on routine health information systems. In it identifies that routine health information systems, the performance can be influenced by behavioral, technical, and organizational factors. There are multiple elements in terms of being able to identify whether it's in the process part of it, how to improve its performance, and thereby affecting the improvements on health systems and the health status. But ultimately, it will boil down to the technical factors, organizational factors, and behavioral factors. For the quick stats and demographics, we performed 29 key informant interviews and 7 focus group discussions on 49 respondents, with 16 of our participants coming from the pilot sites of universal healthcare here in the Philippines, and 17 of them coming in from various municipalities. Municipal classes will be from first class municipality all the way to resource limited municipal areas. We also have, in terms of demographics, conducted this 11 representatives from national agencies, 10 at the regional level, 1 at the provincial level, and then 16 municipal and 11 at the city level. Most of our respondents, 69.4%, are females, and a little over half of our respondents also are healthcare workers. So let's start. As to the data flow, and this is from the subnational and the national, you will see on the diagram on the left-hand part of your screen that mostly in the Philippines, it uses a bottom-up approach, coming in all of the data that's being gathered, whether it's formal or informal, coming in from the barangay health stations, which will be the village health centers in other countries, and how all of these get to be submitted at the RHU level, which then gets validated. All of that gets also submitted to the local chief executives, local health board, and municipal and city councils. And then the Center for Health Development is the regional level in the Philippines, wherein we have 18 regions, which then undergoes another level of data validation before it goes to the central office or the national government's headquarters. So all of the data should be gathered such that it's able to respond to the actual problems. But for that to be able to happen, it should be timely, it should be accurate, and it should be complete. So, so the most available and validated data, that is what should be used for decision making. And what we realize is that in terms of data flow, it requires multiple stakeholders, a multidisciplinary approach in terms of the collaboration. And this is just for the data flow. Government and NGOs really should take a part in routine health information systems processes, as well as all of the data that's being collected, because data should not just be limited to the public sector, the government sector, a lot of the data coming in from the private sector, specifically on with primary healthcare facilities being set up at the private sector. Those will be very, very crucial for the national government or our Ministry of Health, Department of Health to be able to arrive at accurate decisions. Data use at the subnational level, there really is a need for the evidence to support all of the decision making and to push forward policies for health with the devolved or decentralized setup for the Philippines. Very, very crucial that all of that data that is gathered at the local level gets to be transmitted much earlier than it's happening right now for the local chief executives to act on evidence-based decisions in order to improve health service delivery as well as support planning and monitoring of health programs if there are any tweaks that need to be performed on existing programs. Very, very crucial that those are anchored on real-time data, ideally. At the national level, data use is how it's utilized is to be able to support planning, monitoring, and evaluation of health programs and services, and to create and review benefit packages for specific diagnoses and diseases here in the Philippines. So that's for data flow and data use. Right now, the slide shows the different barriers to greater use of RHIS data at subnationally and then later moving on nationally. Following the PRISM framework, we have categorized the barriers in terms of human factors, organizational factors, and technical factors. On the human factor side, there is a need for to build up the human resources base, having designated staff to conduct routine health information system tasks. In the Philippines, as a lot of our audience members will note, at the local level, they have multiple roles and they perform multiple tasks in that, just because it's a little bit difficult at the local level to be able to fill in all of that tasking that's required to be completed by multiple people given limitations on resource. Competence and skills, obviously there's a need to build up the skill set of the human resources who will be working on routine health information systems. Organizationally, public and private collaborations are few and far between, and there is a need to leverage what the private sector will be able to provide, at least in terms of being able to collect all of that routine health information, and the modification of the indicators that oftentimes take a lot of work and that more than regular, oftentimes turnover and revisions to the indicators sometimes have an unintended consequence in terms of how the data will be used for decision making at an earlier time, and with inconsistencies as well. At the technical front, infrastructure, very, very important. A lot of our respondents indicated that internet connection, its stability is crucial for them to be able to submit all of that data in a timely fashion. So with most of areas in the Philippines coming in from places with unstable power grids and intermittent internet connections, that's something that has to be top of mind and should be prioritized by the government. Redundancies also on data collected continue to persist, and there is a need to be able to make all of that be more efficient data-wise. At the national level, obviously there is a need to improve for the timeliness of all of the data. Those who have been requesting data to be able to analyze them even further, and to make decisions and other correlations. They are oftentimes left stuck with data that's as of X months ago or X years ago. So that's something that needs to be considered as well. Data quality and data validation, very, very important steps in terms of data management. However, these need to be more streamlined and have a standardized approach in terms of checking all of the data that gets submitted at each level of the process. And then communication gaps, very, very important that there's clear and constant communication. The channels are really open for all parties to be able to take advantage of all of the data that's available at the national level. Strategies to greater use of RHIS data include institutionalization of capacity building or training and additional manpower. These are, as mentioned, these are recommended strategies by our respondents in order to better use routine health information systems. They have mentioned that there really is a need for plantilla level positions at the government, at least for government institutions. Organizationally, programs for local policy development need to happen with a review of RHIS indicators that are very, very much sensitive to the local needs in terms of what is endemic for that particular locality and what needs to be prioritized by the local chief executives. And technically, quality resource in infrastructure, again, that's something of a critical piece of the puzzle, integrating all of that into an integrated health information system, or IHIS, and a centralized data source for all of that data. Nationally, public and private collaborations continue to be included as part of the next steps and future plans. COVID-19 has opened our eyes in terms of what could be possible if all of the sectors, government, private, from the NGO, civil society, etc., work together to make sure that all of that data gets submitted in a more timely fashion. Policy-wise, there is a need to create policies in terms of funding and how to standardize all of the data that gets collected at each level of the health system. We also mentioned the need for training and capacity building, as well as the interoperability of all of our disparate and siloed systems at each level. So the Philippines, as part of our implementation of the universal healthcare, should really find ways in order to facilitate how to achieve the Philippine Health Information Exchange that will be very helpful for UHC implementation. So how did COVID affect RHIS? You will note that the COVID data, it's not necessarily routine in the truest sense of routine health information systems, but if like somebody from outside of Earth will come in, they will really realize that that's COVID has been part of RHIS for a very long time, at least for the last 19 months. Subnationally, how it has affected RHIS collection and use is highlighting the use of technologies and fewer RHIS data. COVID has made a lot of disruptions in terms of the processes, the data use, the data flows, and how it's being analyzed at each level of the health system. So that has been a major challenge at each level, whether it's a local, regional, or national. Communication gaps still need to be improved on. Even if we have all of these technologies in place, there are still certain nuances that need to be improved in terms of collecting all of that data, and highlighting the role of the disease surveillance officers and disease surveillance units, how all of that really has been ingrained as part of RHIS data collection. National, there's been a stronger public and private partnership, as we have mentioned, and implementation of COVID-related health information systems, like vaccination certificates, vaccine information management systems, interoperability of contact tracing applications. We have our our centralized case surveillance system. So all of that has shown the evidence that this is something that could be doable if everyone, let's say we have an all hands on deck approach. The value for quality information and real-time data will be very critical, in highlighting the importance of relevant laws and policies to date. And again, highlighting the roles and the critical roles and functions of our disease surveillance officers and units in the Philippines. For universal health coverage, although we are just in the auspices of and initial stages of universal healthcare, there really is a need to be able to lay out a plan that hinges on how all of the data that's being collected right now could be improved, because in order to arrive at timely decisions, there is a need for accurate data, and not just for processing of electronic claims. We understand that's a priority, especially at the local government level, because that's where all of the national health insurance reimbursements are based on, but more so on, are we providing value-based care for all of the Filipinos and for all of those who will be availing of the UHC benefits. Operation-based services and basic public health needs continue to be important elements in the implementation, but having less of financially motivated approach, instead shifting that mindset to better decision making at a timely fashion, could be our way to accelerate universal healthcare implementation. Nationally, there have been recommendations for our participants to veer away from additional processes and to inculcate with existing staff and those who will be newly onboarded, an information culture, the importance of collecting all of that data, whether it may be mundane or too routine, not to use RHIS as a pun, to be able to set that culture at the local level, regional level, and the national level. Leadership and governance remain important in terms of advancing that agenda, which obviously has consequences in terms of achieving universal healthcare and interoperability of all of our siloed health information systems. We'd like to thank all of the partners and our study participants and agencies that have been very supportive in this endeavor, in this study. And thank you so much. We hope that we'd be able to share our final results for this study very soon. And let me transfer the floor to our colleagues from Gadjah Mada University in Indonesia. Thank you.
Hi, Dr. Lutfan, do you want to start with your presentation before we go?
Yes, yeah, thank you. Okay. So, yeah, can you see my slide?
Yes, we can.
Okay. So, yeah, thank you very much. So it's really a great honor for me to be in this forum, and we would like to actually share our preliminary findings that we have so far. And yeah, due to the time constraint, maybe we only select some of the key issues that we think important to be highlighted. And actually, we use the same framework as Dr. Sarminto presented. And just to see the context that, yeah, in Indonesia, we implement the health decentralization policy since the year 2000s. And yeah, from that year, then many regulations, including in the many implementations, including in the health care services, are at the district level. And so far, we have more than 500 districts, which is yeah, actually consider a lot. And so far, in terms of the effort to be universal coverage, now our health insurance members are reaching 83%, which is actually expected to be universal health coverage in the year 2024. So yeah, this is to show you the context. And yeah, to see the situations, there are actually many applications already on the field related to the routine health information system. And this is also, I think, to answer the questions related to the data flow, that actually there are many health programs at the national level develop the applications that the entry data are at the hospital as well as the primary health center level. So it's in the subnational level. It is why then if you meet the people at the primary health center level or at the district level, they may say that there are a lot of applications at the field that they have to entry, and of course that this is burdens for them. And this has been actually many years that we are facing these situations. And the words that commonly appear when we have a discussion with them, when we have an interview with them, are the fragmentations as well as the burdens of the data entry. And this has been some years already. It is why during the last few years, there has been many actually initiative try to handle these situations. But yeah, just to show you how they perceive, especially if we see the people, the policymaker at the national as well as at the subnational level, district or provinces, yeah, they actually use routine health data, but it seems that there is variations between national and the subnational level. In the national level, they use more the data survey, which is conducted at least in the durations of 3 years to do the planning program at the national level. And the things that the routine data have quality issues such as the timeliness, the accuracy, etc. And usually also for the purpose of the planning at the national level, they need more specific questions. Just for example, why people don't come to the hospital, which is not yet probably available from the routine data. But this is a little bit different if we see at the province as well as at the district level, which is more routine data are used because this is actually the data that are collected at the health facility at the district level, and they rarely have access also to the survey data conducted at the national level. And this is the highlight of the difference between the national and the subnational level. And there are key barriers which is we identify from the discussions with them that cover the technical organization as well as the behavior aspect. The technical issue is related to the fragmentations of the program, which is actually due also to the organizational issue that there are sectoral echo, that each program have develop the specific system for their program. And there are many health programs actually, and in the primary health center there will be more than 10 programs that should be entered, and this is then make the situations that redundancy, the double entry are the common problem that they are facing. And of course that the technical issue also related to the infrastructures that in Indonesia there are very between district and area, especially in eastern part of Indonesia. The infrastructure is considered not yet developed as in the western part of Indonesia, but during the last few years there has been initiative to improve the infrastructures in the eastern part of Indonesia, and also that the data quality are not yet actually good because of the limited data validation system also. And in terms of the organizational aspect, there is also the policy interest, political interest that some, especially in the district level, they have a political issue that actually will be prioritized, although maybe considers not the things that appear based on the data, but since that this is actually to satisfy the community, the people, then they may actually prioritize the political interests in the first hand rather than the issue that based on the data. And on terms of the behavior aspect, the limited awareness of the importance of the data is actually still a big problem, as well as the confidence of the routine data quality. And for the last few years, actually there has been many innovations to promote and strengthening the routine health data. In 2019, Indonesia released the One Data policy that actually aim to integrate and also to improve the data sharing and data use among the government agency. And this still ongoing process. It's not yet actually achieved, but during the COVID, it's somehow faster the process, because the need to communicate and also to do the data sharings are necessary. And actually, one of the strategy that has been one of the priority from the Ministry of Health is also to forming a digital transformation office, which is just recently released in 2020, and this are now still ongoing projects that expected to facilitate the regulations, data integrations, and also to facilitate the use of the routine health data. And besides the Ministry of Health, the National Health Insurance Agency is also use the claim verifications to facilitate the claim at the hospital, which is then will be also very important to somehow improve the use of the data, the routine data. And in 2019 and 2020, the National Health Insurance Agency released what's so-called the data samples that consists of about 1 million individual data that has been de-identified, and this can be used by external stakeholders to actually, the idea is to improve the access as well as to improve the use of the data that has been collected by the routine data from the National Health Insurance Agency. And at the subnational level, there is also policy to strengthen the use of the routine data. In 2018, there is a presidential mandate to use the electronic-based system at the government office, which is now started to be implemented in many districts, although not yet complete, but there has been actually effort to do that one. And it seems that although it has been already some years ago, but implementation is still facing the difficulties in the field due to the infrastructures as well as the capacity of the human resources. But in some area, especially in the west part of the Indonesia, then the effort to integrate the data are actually one of the priority. So just for example, in Jogja, which is one of the locations where we conducted the study, they already have the data integrations that link between the civil registration data as well as the health data from the health facility with other also data sources like the environment and education. And this is actually very important also in terms of the pandemic to respond to the to the pandemic. And the National Health Insurance is also have a data sharing forum that actually at the district level, and because before the district government is actually have difficulties to access the data related to the health insurance, so they don't know how many people that already become the membership of the health insurance, as well as actually the issue is that because there are many diseases that very costly, and this make the national health insurance deficit, which is actually located in several districts, and the district government is actually not aware of these situations. But then now the national health insurance is sharing the data also about this, so that the district also aware of the situation. And related to the MCH program, there's also initiative to do the integrations to link between health data and also other data. Just for example, related to the village information system that consists of many other administrative data at the village level. And especially during the COVID, there is also a need to integrate because of the disruption of many health programs. Then this data are necessary to be linked to actually resume the just for example antenatal program that has been actually disrupted during the pandemic. And some of the districts now also do the site visits to ensure that the maternal health program are actually resumes and that the healthcare services can be actually run. And there has been also many training and effort to improve the awareness among the health workers at the district level, especially for the MCS program. And the pandemic has improved the appreciations of the data. There has been more intensive communications between national as well as the subnational government. And the data sharing and also data linkage are actually happen also, which is not the case before the pandemic. And an example are the PCare applications. This is actually the applications from the National Health Insurance at the primary care that now is linked also with vaccination data, as for example, which is actually from the Ministry of Health. And this is also case awareness to data sharing and data linkage are increasing, and somehow increase the complete and availability of certain data, especially the MCA data, that in district that we are observing, they says that due to the COVID, the allocations of the health fund is also more flexible because of the pandemic situation, especially to deal with the MCS program, which is has been disrupted before due to the pandemic. And the pandemic is also promote the innovations that now the interoperability and also the communications between HRS are increasing, and also some of the innovations that appear during the pandemic are the telehealth, which is actually quite slow before the pandemic. Indonesia actually has implemented the telemedicine by the year 2012, but the adoptions are very slow, and it has been actually increased dramatically since the pandemic in 2020. And there has been also main digitalization in process of collecting and reporting data that now become one of the priority to easier the data collections from the district level, from the health facility level. Yeah, I think that's all that we can share. And yeah, maybe we'll continue with the discussions later on. Thank you.
And thank you very much for both of those comprehensive presentations. We're coming close to an end. I don't see many questions. The only questions I've seen, I think you've answered, which is about Indonesia. How do you manage data flow from village districts, subnational and national? Let me come up with slightly different questions. We've seen two different systems. A presentation where it shows quite well the linkages between the financing, the BPGS, using health information system. Let me bring Raymond here. And Raymond, what are the challenges that you find with PhilHealth using routine health information system? And I want to go just because through the angle of health financing, because frankly, unless there is money linked, you're going to find it difficult to expand and use RHIS. So what is the situation, what the challenges when it comes using PhilHealth, which is in theory, a different organization? And on the same basis for both of you, and also please Karen and Tiara, what happens, what's in it for them, for the private health sector to join, to do this? What do they get out of it?
Okay. Thank you, Nima. For the Philippines at least, the coverage for all private health, for all public health facilities that are using any semblance of an electronic health record is hovering around 70%. That's only for the public sector. For the private sector, it's a little bit less than that. And the reason that I mentioned that is because the only time that the Philippine Health Insurance Corporation would be able to provide reimbursements to all the services that are provided to the healthcare facilities is through electronic means. And they can only do that if a health facility is using a PhilHealth certified electronic health record or electronic medical record system. So you will note that there's a large percentage of the entire primary healthcare sector that does not have any semblance of use of any electronic health record system. So that is a problem if we are trying to move forward in terms of being able to sustain all of the work that's being done. And PhilHealth will only be able to, although it has given exemptions to certain localities and local health facilities. That's not, it's more of the exception rather than the rule, Nima. So there's still a whole lot of work that needs to be done just to bridge that final mile, if you will, so that everyone is included in that work. So in the second part will be, what does the private sector gain, if I understood you correctly, in terms of being able to participate in that? I think being able to open those channels and being able to realize the benefits of a public and public-private collaboration really will open up not just how all of the data will then be providing let's say a 360-degree picture of the entire healthcare sector, but also what are the inefficiencies as it relates to connecting a patient that will need to be referred, maybe has been seen in a local primary healthcare facility, and then will then have to be will have to undergo like surgery for X, Y, and Z case in a private healthcare facility because that's the only one that's available with the available equipment, human resources, and space in their hospital in that particular locality. If there's no connection between those two facilities, it's very hard for that to be I mean, if we are going to call that a good example of universal healthcare. So that's part of the barriers that we are looking at in terms of the data that gets to be processed. Just because we do not yet have, at least in the Philippines, a widespread national ID system, that's something that has to be prioritized as well as we move towards I optimistically call the denouement of the COVID-19 pandemic. We are looking into how we could prepare the runway for universal healthcare implementation.
Thank you. I'm cognizant of the timing, and we are running out, and we have May Valesco to do the closing. So let me bring Tiara in here next. You've been sitting there very patiently. What are your thoughts? Same questions. Or rather, what's in it for them? I have concerns from Raymond, because what Raymond was saying was much more about the systems point of view, as opposed to the private sector. It's a financial, they want to make money. Why should they share the data? So let me put it that way for you. Why should the private sector in Indonesia want to share or want to invest in developing that?
Yeah, I think it's a bit similar, because in Indonesia, the only way you can get reimbursement is through the e-medical record system, which is uniform for all hospitals, both private and public, that are joining BPJS or the insurance agency. And also it's 60 to 70% of our healthcare services, particularly hospitals, are in the private sector. And with 89% of the coverage of the health insurance system, they have to be in the game, right? So maybe they don't want to share the data, but they kind of have to to get the money. I think the barrier is the use of data and the interpretation of the data. It's only in recent years that we have access to sample data of the BPJS, or the health insurance reimbursement claims. And that needs to be explored on, equity issue, service quality issue, and all that. And I think some feedback to the hospitals, including the private ones, would also be useful, but that's still to be, we're still waiting for that to be happen.
Thank you. Lutfan, any comments? Anything to add?
Yeah, I think it's not directly related to the incentive issue, but it's actually linked to the just for example, if we don't use healthcare services don't use the data from them, then it will also impact this report to the financing. and it's also then why they have to use the system then. But yeah, now it's I think going concerns also that the use of the data is increasing because of the need also. Just for example, during the pandemic, and I think this is good examples that now they realize the data are important.
So does that mean that there is incentives for providing data? Do they get extra funding? Or is it just
actually indirectly, I think, because I mean some of the application is actually linked with the financial report. Just for example, the BPJS, the PCARE, which is actually the data, the electronic medical record from the BPJS, then will link with the number of the capitations. Will so in case that the data is not entry, then the number of the capitations, which is actually money from the BPJS, will not come.
Okay. Thank you. Yeah. Karen, last remarks.
No, I think, I mean, I think both teams made some really interesting points, interesting discussions. I think we're still sorting out how COVID has changed things. I do think COVID has increased both the value and the potential benefits of these data. I think the awareness of the data has changed dramatically. And so I think as a result of that, there might be more interest from different actors to think about to appreciate the value of sharing data in a more open way. But I think we're still at an early stage in terms of, the dust hasn't settled yet, and therefore there's still a lot that needs to be resolved and how practically that will happen in the future.
Okay, I mean, as somebody who used to set up surveillance system, there was always this tension between the routine hospital information system and surveillance databases, and different purposes fundamentally. But yes, it'd be good to see how COVID is something which is bridging both of those. And with that, you bring in the vaccine information and ability to move and linking all of that together, I think opens up some cultural discussions as well about open societies, etc. Well, thank you very much, all of you, for this another fascinating conversations. I've learned so much today from all the various presentations and conversations. Again, thank you for your time, and I look forward to seeing the final report, which I believe is supposed to be here in about a month's time, Karen. Can I now do two things? I would like to, first of all, put up a slide, which is for our attendees, because there is a request that they should do the review. So let me share that slide first. And while that is up, so that you can, the attendees can, and oh, that's the wrong one, sorry. Give me 1 second, because there's a request for them to review and comment on this. Can you see the DoH APO feedback slide?
Yes, we can.
Okay, good. Okay. So that's that. And with that, can I ask Dr. Gloria Velasco to give the final few words about today? Today was a gallop through 4 main projects that APO is doing, where Philippines is a major partner in all of them. We have a couple of other ones as well, but these were the 4 main ones. We have something on AMR as well, which includes the Philippines. For those of you who don't know, Dr. Velasco is the chief of the Health Research Division at the Health Policy Development and Planning Bureau at DoH in the Philippines. She's been working at DoH since 2012. And she has a master's from Institute of Tropical Medicine in Antwerp, and her professional interests include health policy, financing, strategic planning, and decision-making in context of health system strengthening. And her most recent work was on development of standards for national public health programs, something which fed in quite well, I think, in the earlier presentations as well. So with that, may I ask if Dr. Velasco would like to give the final few words, and please do let me know if you want me to take the slide down, because right now it's the slide at the moment.
It's all right, Dima, you can just leave it on. Thank you very much. Very quickly, and on behalf of Director Mamaril, it is a great honor for me to have this opportunity to thank you for attending the DoH APO Special Research Forum. This forum was conducted to build a stronger appreciation for and utilization of health research and evidence, and we have been joined by several international and local researchers and experts that have shared the results of their research and, more importantly, emphasized key recommendations for those working at the national and local levels. We look forward to taking all the lessons we have learned and reflect on how we can use these to contribute to improving our health systems and in our respective roles. As for the Department of Health Central Office, we find the evidence presented and the insights shared to be useful in health policy development, and we aim to examine these more closely and consider them in our internal discussions and dialogues with other stakeholders. As we end the forum, we would like to thank our speakers, our panelists, and of course, the APO for generously sharing their valuable time and insights with us, and we are truly grateful to you. We would also like to thank all the participants from the various DoH units, the attached agencies, and our research partners. Thank you to all for being with us today and making this forum successful through your engaged participation. Once again, thank you very much and good afternoon.
Thank you very much, Dr. Velasco, and thank you again to all of our panelists this morning and this afternoon, and also to all the attendees who joined us. It's a privilege to share with you the work that we are doing, and hopefully you'll see the benefit of some of the work as they become finished and we start publishing them. As I said, you can find all of our publications at apo.who.int. That's where all of our publications are there, and quite a lot of the publications are also journal articles which were supported by APO. So you'll find the repository of the journal articles there as well. So with that, again, thank you very much, and I would like to close this this one-day forum, and hope to interact with all of you in the future. So again, thank you very much and goodbye.